Hello and welcome to the Laboratory Matters, where we discuss all that matters in the laboratory. I'm Dr. Rani Radhakrishnan, and we will continue with our series titled All Red Cells Are Not Discs. We've seen in the previous two modules where we have learned what a poikilocyte is, an abnormally shaped cell, the classification of poikilocytes. We've gone through quite a few of them, which include the spiculated cells, the elliptocytes, ovalocytes, and so on. And now we will move on, where we will cover another group of these abnormally shaped poikilocytes, which are the spherocytes, the irregularly contracted cells, and the sickle cells. So we finished these and we shall now discuss the last three in the group. So let's start with spherocytes. Spherocytes are another type of poikilocyte which we encounter very often in the laboratory when we are reviewing peripheral smears. So these are cells which are nearly spherical, going by the name a spherocyte. So all these spherical looking cells. Okay, now you can say all RBCs are also spherical. Yes, these are also spherical, but what is the difference between a normal RBC and a spherocyte? On a well-stained smear, you will see that these spherocytes are not only spherical, but they have no central pallor. It's a completely homoglobinized cell. Now, this is the only red cell which is hyperchromic. Please understand, it's hyperchromic, means increased color. So, there is a raised MCH and a raised MCHC. It's the only cell with a raised MCHC. Now, there is a loss of erythrocyte membrane without equivalent loss of cytosol. And that is why it becomes contracted and becomes a spherocyte. Now, these spherocytes can be all uniform, smaller than a normal red cell when it becomes a microspherocyte, or it can be normal sized cells which are spherocytic in nature. So there can be some difference in size, and that is also important. So when you're seeing spherocytes on a smear, you have to look and see whether it obviously makes up more than 10% of the total number of red cells. Only then it is clinically significant. After that, what is the size? Are they uniform spherocytes having the same size, or are they, diverse in size, small cells, large cells? And then you have to look at the other associated features before you can reach a diagnosis. Now, in all smears, let me tell you this. When you come towards the tail end of the smear, which you're not actually supposed to examine for the morphology of any cell, but the tail end is something that we look for presence of clots, presence of fibrin, presence of any other aggregates. So, if you look as you come towards the tail from the ideal zone, moving away towards the tail, you're going to find a reasonable number of cells that are spherocytic in nature, which is mainly because of the smearing. So that is not the place where one would look for spherocytes, because if you start looking towards the tail, almost everybody will have spherocytes on their smear. So you have to look at everything in the ideal zone. For morphology, that is the area where one should concentrate. So if you find numerous spherocytes across the smear, then one has, and if they're uniform in nature, same size, looking beautiful, then it is a hereditary spherocytosis. But if it is just hemolytic anemia, a hereditary spherocytosis can also give rise to hemolysis, where you will find slightly larger cells or normocytic cells which are spherocytic in nature. But other cases of hemolytic anemias like warm autoimmune hemolytic anemia, a delayed hemolytic transfusion reaction, ABO hemolytic disease of the newborn, RH hemolytic disease of the newborn, Clostridium perfringens sepsis, snakebite-induced hemolysis, drug-induced hemolysis, burns-induced hemolysis, all this will give you plenty of spherocytes on your smear. So if you are looking at a smear and finding plenty of spherocytes, then you should think of hereditary spherocytosis first, especially if it's uniform, or other causes of hemolytic anemia. Now, when spherocytes are associated with other poikilocytes, that means you have more poikilocytes other than spherocytes. So in a normal neonate, this is common. You will find spherocytes and you'll also find some schistocytes. You'll find the other target cells. You can find all this in a normal neonate. Hyposplenism, okay? Sickle cell anemia, microangiopathic hemolytic anemia. This is microangiopathic hemolytic anemia where you find fragmented red cells and schistocytes of different sizes. HE with hemolysis, any of these membrane disorders with hemolysis, even hereditary spherocytosis with hemolysis, hereditary pyropoikilocytosis, burns. This is burns where you find such small red cells along with some amount of budding. So any of these conditions where you find other cells, then you have to think of these red cell abnormalities, which could be MAHA, sickle cell, or HE with hemolysis, hereditary pyropoikilocytosis. So looking at the smear, once you pick up the main poikilocytes, you also look for the associated cells, and only then you'll be able to arrive at a diagnosis. Now, what are the causes of spherocytes? Okay, what are the causes of spherocytes? So, the cause of hereditary spherocytosis, as the name suggests, it's hereditary and therefore it's a genetic defect. There is an abnormality in the cytoskeleton with a secondary destabilization and loss of membrane proteins. So there are abnormalities in spectrin, ankyrin, pallidin, band 3. Now one should understand that these proteins that make up the cytoskeleton, the abnormalities in them give rise to various types of abnormalities in shape in the red cell. So in the case of spherocytes, it's again an abnormality in either spectrin, ankyrin, pallidin or band 3. It can only be in different points. Now what are the acquired causes of spherocytes? I told you when we saw the spherocytes along with other poikilocytes, you can have a host of conditions which can give rise to the presence of spherocytes on the peripheral smear. Loss of membrane due to interaction between immunoglobulin or complement coated red cells and phagocytic cells. So this could be in delayed transfusion reactions, ABO hemolytic disease of the newborn, or autoimmune hemolytic anemia. In these conditions, it can be because of a coating of the red cell, giving rise to some kind of an antigen-antibody reaction. So it can either be coated by immunoglobulin or it can be coated by complement. So because of this, these red cells are phagocytosed and you can get hemolytic anemia. The other causes are direct damage to the red cell, which will be because of heat or from the action of bacterial toxins like Clostridium perfringens, lecithinase, snake venom. Here the red cell membrane itself gets damaged, so there is loss of red cell membrane and therefore this leads to the formation of a spherocyte. A spherocyte may be seen in association with other poikilocytes like I discussed a little while ago in hemolytic anemia of various types. Now this is important. When you transfuse stored blood, all blood that is transfused is stored blood. Okay. And then you look at the smear the next day morning, you will definitely see the presence of spherocytes, and along with spherocytes, you will see spheroechinocytes. I discussed this with echinocytes when we did it in the previous module, where post-transfusion, the easiest method to diagnose whether this patient has been transfused, apart from of course calling up the doctor or the ward nurse and asking, is to look for the evidence of one, you will find a dimorphic population of cells. Two, you will find spherocytes or spheroechinocytes. So these are also other causes when you will see spherocytes in the peripheral blood. Now, the presence of a uniform population of slightly smaller red cells or microspherocytes across the smear is quite diagnostic of hereditary spherocytosis. However, what are the other tests that you can do? One is osmotic fragility. This is an age-old test. However, it is not very specific and it can give rise to a lot of false positives. So you do incubated osmotic fragility where you incubate the sample at 37 degrees and then repeat it. And this is considered to be more specific for HS than for other tests. EMA binding by flow cytometry, glycerol lysis time, acidified glycerol lysis time, cryohemolysis, autohemolysis, and lastly, or the most specific one, is the membrane protein analysis. Now, normal labs can do osmotic fragility and MAX can do an incubated osmotic fragility. The rest of the tests can only be done in those labs which are centers of excellence or dedicated reference labs. So, in a normal day-to-day diagnosis of hereditary spherocytosis, we look at the CBC, we look for an increased MCHC, we look for evidence of hemolysis, look for the presence of a uniform population of spherocytes, and if possible, do an incubated osmotic fragility test, take a family history, find out if there are other members of the family who may also have the disease, and then go ahead and diagnose it. More often than not, again, hereditary spherocytosis is also something that you pick up when you're just doing a review, most probably in a mastral checkup or something like that is when you will try and pick up many of your cases of hereditary spherocytosis. Now, other tests in the presence of spherocytes. Okay, I'm reviewing a smear and I'm seeing plenty of spherocytes. What else should I do? Should do a retic count. Why do I do a retic count? An increased reticulocyte count is significant and it could signify hemolytic anemia. A direct antiglobulin test to know whether the hemolytic anemia is because of the presence of, say, drugs or any other kind of anything else that could have triggered an antigen antibody reaction giving rise to hemolysis. An indirect antiglobulin test is for similar reasons. Total direct and indirect bilirubin. Obviously, when you're looking at a case of hemolytic anemia, the total bilirubin will be increased, as is the indirect fraction, which signifies hemolysis. Lactate dehydrogenase again will be similarly increased. But the most important test to diagnose the presence of spherocytes and the cause for the presence of spherocytes is a very detailed examination of the peripheral smear by an expert, by someone trained to look at peripheral smears and trained to look at red cell abnormalities. So it's not just enough to pick up spherocytes, you have to pick them up and you have to determine the reason for the presence of those spherocytes in the peripheral blood smear. Now we move on to irregularly contracted cells. As the name signifies, these cells, which you can see marked by the arrow, they lack central pallor. They are smaller and denser than normal red cell. They are not regular in shape as the spherocytes. Therefore, they cannot be called a spherocyte. Irregularly contracted cells are formed when there is an oxidant damage to the erythrocytes, or there is a damage to the red cell membrane by precipitation of unstable hemoglobin or free alpha or free beta exchange. So there is some insult to the cell, because of which it loses a large portion of the cytoplasm and becomes an irregularly contracted cell, which you need to look for if you're trying to find them. Now they are seen, like I said, whenever there's oxidant drug or chemical induced hemolytic anemia. Hemoglobin C disease, more common in hemoglobin C because it crystallizes to form these irregularly contracted cells. Hemoglobin C beta thalassemia, where in the association of any hemoglobinopathy or thalassemia with hemoglobin C, you're going to find irregularly contracted cells, and these are quite pathognomonic and diagnostic of hemoglobin C disorder. Then, like I said, in unstable hemoglobinopathies, severe oxidant stress, all that it will, you will be able to see these irregularly contracted cells. So it's important that you're aware of them so that you can diagnose them. Now we move on to sickle cells. Sickle cells, again, if you worked in a dedicated hematology laboratory, you'll find plenty of them. If you work in a dedicated orthopedic hospital also, you will find plenty of sickle cell anemias. So sickle cells are so called because they're shaped like a sickle. And that is again due to the presence of an abnormal hemoglobin called hemoglobin S. Now, how is hemoglobin S formed? It's when glutamic acid is replaced by valine in the 6th position of the HBV gene on chromosome 11. So the hemoglobin chains are coded on chromosome 11, and when there is a mutation in the 6th position, then that resulting hemoglobin is called hemoglobin S. So what is the problem with the hemoglobin S? It can just exist like so many other hemoglobins exist. The problem here is that in conditions of deoxygenation, or when the oxygen levels are low, the hemoglobin molecule or the tetramers will polymerize, and that will result in rigid sickle-shaped cells. So basically, the presence of hemoglobin S, that will lead to these erythrocytes or abnormal erythrocytes becoming rigid. They cannot be deformed, and therefore when they are passing through the blood vessels, they can join together, aggregate together, and cause occlusion, and this is what results in a vaso-occlusive crisis. So these patients with this abnormal hemoglobin, they can present with anemia, jaundice, splenomegaly, with or without a painful or a vaso-occlusive crisis. So when they present with that, it becomes an emergency and you need to treat it. So this sickle cells are endemic in many portions of the world, and even in our country you find pockets where you have these sickle cell people with sickle cell disease. Now, how do you diagnose sickle cells? One, if the patient has sickle cell anemia, that is, he's homozygous for sickle cell. He's inherited one gene from the father, one gene from the mother. Or you can be heterozygous when you just have the sickle cell trait. Okay? So in a full-blown sickle cell disease, when you're looking at the peripheral sphere, the chances of seeing sickle cells are there. These are sickle-shaped cells which look like crescents or crescent moons. And in the presence of plenty of targets is a sickle cell anemia. So a CBC, a detailed examination of the peripheral blood film, reticulocyte count obviously to look for evidence of hemolysis, and a sickle cell preparation or a sickling test where you mix equal quantities of blood with sodium metabisulfite, and sodium metabisulfite removes the oxygen, giving that blood sample a deoxygenated condition, forcing these cells to sickle. And when you take a unfixed or a fresh specimen and put or mount it with a cover slip and look under the microscope, you will find that you will have plenty of sickle cells. So this is a very easy test that one can do in the lab, except that when after you incubate that mixture and you put it on a slide, you have to ensure that you seal off the four edges of the cover slip so that you don't allow oxygen. So this is reversible. If I just put a cover slip and I don't seal the four sides, oxygen will enter and these cells will again start becoming normal. So this is not an irreversible condition. This is still a reversible condition. If you let it go and the cell continues to be deoxygenated, it will become an irreversibly sickled cell. So this is one method of diagnosis. But what is the gold standard? It is either hemoglobin electrophoresis or it is a HPLC or high performance liquid chromatography. So when you run in HPLC, you run the sample on a cartridge and where it is running across an electric current and the different portions of the hemoglobin elute out and they form these various graphs. So this is hemoglobin A or adult hemoglobin, this is hemoglobin A2 and this is an abnormal hemoglobin that is, the graph is being formed. The retention time is around 7 minutes and this is your hemoglobin S. When it is greater than 50%, it becomes disease or homozygous, and when it is less than 50%, it is sickle cell trait, may or may not be associated with other conditions. So this is from a HPLC count. You can also do a gel electrophoresis of your hemoglobin, where in a gel it runs from the positive to the negative pole and the various hemoglobins get eluted out and they form a graph-like structure. Here again, this is how the gel looks. So where it's run, you will scan it and the graph will appear. So this is hemoglobin S and this is A and this is hemoglobin A2. So you have almost like 50 or 60% of hemoglobin S and therefore this is sickle cell anemia. So that's the method or the gold standard for diagnosis of sickle cell anemia. You can have a heterozygous sickle cell anemia where you'll have greater than 50% HbS. Heterozygous is the trait, you'll have less than 50%. Homozygous is the disease where you have more than 50%. Then you have sickle cells in association with other abnormalities like a hemoglobin SC disease. S and C will migrate at different points and the presence of both this will be SC disease. Or you can have hemoglobin S in association with either beta plus or beta naught thalassemia. So with hemoglobin electrophoresis or HPLC, when you're looking at the graphs, you'll be able to easily diagnose any of the diseases either in alone or in combination. So for the diagnosis of sickle cell anemia, you need to have either hemoglobin electrophoresis or you need to have a HPLC. So these are the three different types of cells that we discussed: the irregularly contracted cells, the sickle cells, and the spherocytes. Now, what are the take-home messages? Spherocytes are near spherical in shape with an increased MCH and an MCHC, and on a stain smear, they appear as cells with no central pallor. They can either be inherited, which is hereditary spherocytosis, or it can be acquired because of various causes of hemolytic anemia. So they're seen in hereditary spherocytosis, warm autoimmune hemolytic anemia, delayed hemolytic transfusion reactions, ABO hemolytic disease of the newborn, and so on and so forth. Now, irregularly contracted cells lack central pallor and they appear smaller and denser than the normal erythrocytes, and they are seen whenever there is an oxidant damage or a drug or a chemical induced damage to the red cells resulting in hemolytic anemia. Also seen with hemoglobin C disease where it's quite pathognomonic, and hemoglobin C are associated with beta plus thalassemia. Sickle-shaped red cells are formed due to the presence of hemoglobin S, and one should be able to pick them up on the smear. Otherwise, you will have to do either a HP electrophoresis or a HPLC for diagnosis of sickle cell disorder. So with this, we have finished discussing the various poikilocytes that are of clinical significance, how they are formed, what is the etiopathogenesis, if possible, wherever possible, the molecular basis of the formation of the cell, the clinical conditions that they are associated with. I hope you enjoyed listening to the last 3 modules. And if you did, you can continue watching it for our final episode on how to look for the presence of poikilocytes. Are there pointers in our CBC report, in our scatter plots, in our histograms? So that will kind of bring us full circle, and we'll be able to start looking at all the pictures that are generated from the cell counter to reach or to diagnose a poikilocytes. If you've enjoyed this module and this series, I'd like you to go and visit us at thelaboratorymatters.com for more such videos, more such courses, and more information according to your likes, according to your taste. If you've liked it, kindly like us, comment or share us so that it can give a better reach and you can continue to watch us at the Laboratory Matters. Happy learning, and until we meet for Module 4, bye from the Laboratory Matters. Thank you.